to talk to the group.
It's okay. Thank you for asking me. If anyone has any questions during the talk, please just, say them if you want me to stop. So I'm going to, hopefully this talk will be okay and what you expect, but it's going to be a talk about clotting screen investigations and pre-analytical variables for coagulation testing. So first of all, we're just going to talk about pre-analytical variables because obviously, they're very important because the sample quality that we use in coagulation needs to be, as best as we can make it so that we can deliver the right result back to the patient. So as you know, coagulation errors, they occur on any stage of the sample pathway, and the main source of where the errors occur is in the pre-analytical phase, and it's known that up to 5% of samples can have errors in this phase of the sample journey. And we know that hemolysis rates in A and E are higher than any other locations. In the laboratory, usually analytical errors are very well, we don't get many errors in the laboratory because we have well-controlled assays, we're doing IQCs, we're doing EQA, so there's less errors than in the pre-analytical phase. Then we've got the post-analytical, which is about authorization, interpretation, and as you know, all errors have the potential to affect a patient diagnosis or treatments that may cause harm. So the common variables that I'm really going to focus on are the ones that we would, that we think about other patient, what type of collection tube we use, what type of anticoagulant we use in coagulation testing, how we do the order of the draw for the tubes that we take, and also the venipuncture technique. So I'm not going to go into great detail about this, just some key points, and then how we transport the sample to the laboratory. So for patient variables, we all know that we have to identify the patient correctly. They need to be relaxed when they're having bleeding investigations, if possible, and they should avoid strenuous exercise just before their blood test because factor VIII, BWF, and fibrinogen are acute phase proteins, and they go up if a patient is stressed. And the timing of the sample might be important as well, especially if patients are on low molecular weight heparin, unfractionated heparin monitoring, where we need to know trough and peak. When we do post-factor VIII levels, we need to know that optimal level is measured at 15 minutes. When we do a 9 level, the optimal level is 30 minutes. And then we've got to take into account the age of the patient. So babies are always vitamin K deficient at birth, and they have different reference ranges to adults. So when we collect the blood, when we have a coagulation tube, all tubes are the same. They should be collected second after the blood culture bottle. If you're doing a lot of different collections like full blood count, years and E's, the coag must be collected before those two tubes. When you're using the BD system, the tube has a line, a critical fill line on the side of the tube, and it's that minimum fill indicator line. And then we have a maximum fill line, which is just under the lid. And so we must fill the blood up to the maximum fill line ideally, but it must be over the minimum fill line. Otherwise, we get the incorrect ratio of blood to anticoagulant. We also sometimes might have to take into account if the hematocrit is high, and we might need to adjust the sodium citrate in the tube. And so there is a special calculation for that, which I've just put there. And so we have to, just aliquot out the citrate and then put back the right amount if the hematocrit is high. But then you've lost the vacuum in the tube as well. So when we transport it to the lab, ideally we want to transport at room temperature, and the ideal room temperature is 18 to 25 degrees. So we can keep whole citrated blood samples at room temperature for 4 hours before we process them in the laboratory. So longer transport times may have an effect on the sample, but likely PT-INR testing is probably okay up to 12 to 24 hours after you've taken the blood. And just a reminder that you all know factor 5 and 8 are thermolabile, and they can be decreased by much as 50% when stored at room temperature for 8 to 12 hours. And then, over here we have pneumatic chute systems in the hospitals, and they are suitable for transporting samples around the hospital to the laboratory. but not for some of the specialist tests like platelet aggregation studies. So when we prepare them in the lab, we know that we want to prepare platelet-rich plasma, and we use a slower G speed, 120 for 15 minutes. If we want to prepare platelet-poor plasma, which is what we use for all of our coagulation testing, we need to spin the sample for 10 to 12 minutes. We can use higher speeds if you have such a centrifuge, and the usual speed is 2000 G, 10 to 12 minutes. We usually use double spun platelet poor plasma. So we then need to aliquot off the cells into a different container, put that container back into the centrifuge, and then spin it again for 2000 G for 10 to 12 minutes. And so those are, if we're going to do lupus testing, anti-10As, investigation of factors, VWF levels, we like double spun platelet poor plasma. And then we can store that plasma that we've just made, we can leave it at room temperature or freeze it immediately. And then we can store it in a freezer, sometimes for up to 2 years if we have -80. And for -20, we can only usually store the frozen plasma for 2 weeks. And then the quality of the sample goes down. So, and then there's other things that can interfere in the pre-analytical phase. When we put the samples onto the machine, if they're hemolyzed, if they're icteric, if they're lipemic, sometimes analyzers have trouble measuring the endpoint for clotting-based assays. It can also interfere with chromogenic assays. So with hemolysis, we don't test. We say don't test if the sample is hemolyzed, because the sample is then activated. If you've got lipemia in the sample, you can sometimes spin it at high speeds to remove the lipemia and then use that plasma on a machine. If you're doing a manual test, even if you're using in a water bath, you're not going to see the clotting. You won't see the clot form because of the lipemia. You may see it if the sample is icteric, but we have these other small machines which have mechanical endpoints, so they're quite good for lipemia and icteric. And so, okay, so I've said all of that. So then this is just a little summary. So when you're actually taking the blood, if you mix up the order of the draw and you get EDTA into a citrate tube, you can falsely increase the PT, APTT, and thrombin time results. Then that may affect the fibrinogen, and you can falsely lower a factor 5 and 8 level. So then you would say that you can give this false impression of inhibitors to 5 and 8, or falsely diagnose someone with severe haemophilia A if you've got EDTA in your citrate tube. If we've got serum or clotted citrate, obviously we're not going to be able to produce the result because we've defibrinated the plasma and we have false low levels of clotting factors. Therefore, you give a false impression of clotting factor as inhibitors. When the sample's partially clotted as well, you get strange results. So, and you get these flow obstructions sometimes in this different analyzer, but you're giving falsely low, PT, APTT, thrombin time results. If it's underfilled, that also affects the result as well, because you've got the wrong ratio of blood to anticoagulant. And then just another thing, if someone has got warfarin on board, which is an anticoagulant, which affects the vitamin K clotting factors, or if they've got liver disease, they have increased APTT and PT anyway, but falsely decrease. These factors are known to be decreased in liver disease and warfarin as well. So we need to know if the patient is on warfarin or liver disease when we're interpreting these results. It's very helpful to know that. So for the equipment in the lab, you need a centrifuge. Ideally, it can be room temperature or cooled. Needs to be able to do speeds up to 2000 G. We have a water bath. We're always thawing out our samples, and that should have a calibrated thermometer on it. We need test tubes, stopwatches, if we're going to use a water bath to do our tests. We need sterile water, sterile saline to make up our reagents. We need pipettes that have been calibrated. And then when we're looking for the clotting endpoint of the test, we're either going to use a manual, we're going to use a water bath, we're going to use a semi-automated analyzer or automated analyzer. And then we need to have a fridge that can keep temperature 2 to 8 degrees so that we can store our reagents. We ideally need a freezer below 40 degrees so that we can store our frozen PPP plasma samples, and a temperature controlled lab. So when we're doing manual methodology for routine coagulation tests, already said a water bath test tubes, but it's very labor intensive. We have these semi-automated coagulometers, which are 1 or 8 channel devices, and it has an endpoint detection that is done by the machine rather than our eye, but you have to manually add the patient samples and the reagents to the device. And then you've got the automated analyzers where everything is added by the analyzer. So each of these different techniques for doing coagulation tests needs its own reference range, and they will vary by the method that you've used. So I've just put these pictures up to show you, a water bath, some test tubes, a stopwatch, pipettes, and then you've got these little semi-automated analyzers. So the Stego machine has a mechanical endpoint, so it uses a cuvette with a ball bearing in it. And then we've got a Sysmex analyzer, which uses light to detect the endpoint of the clot. And then we've got automated machines here. So when we're looking at a clotting curve, all clotting curves are the same, and how it's all dependent on where the detector is, where we detect on this curve the end point of a PT or an APTT. So when we're doing it by the water bath, we're only going to collect the end of the big fibrin clot that's formed in the test tube. So the clotting time will be longer by manual clot detection compared to an automated analyzer. And so we use a timer to measure the endpoint here. When we have mechanical endpoints, that's fibrin strands, they stop the ball bearing moving and it switches the timer off on the analyzer. That's somewhere up here, a mechanical endpoint, because it needs a certain amount of fibrin clot present for the ball bearing to stop moving. And then we've got these automated analyzers, and they have sort of detection methods about where they're going to read it on this clotting curve. So a Sysmex machine will read it. It looks at the difference in iodine between the clear sample. When you add your reagents, the fibrin clot forms, and then it becomes cloudy, and it takes this 50% point in the middle of the clotting curve, and it says that's the end point of the clot. And then you've got things like ACL top. They read it, they use maths in to analyze the curve, and they read it down at the steepest part of the curve. So you can see how we have lots of different times we can get on the same sample depending on the method that we've used. And so now I'm just going to go through some of the routine tests that we use. So as you know, we've got primary hemostasis, which is all done on the endothelium, where you have injury to the endothelial wall. Platelets go to the site of injury, and the platelet surface is where coagulation occurs. And then this is the secondary hemostasis. So this is physiological hemostasis here, where you've got injury, you get 7A activation, and on down to make thrombin, the enzyme. But when we think about it in the laboratory, we think about our tests. We divide that pathway up into the intrinsic pathway, and we know that the APTT measures the overall function of these factors in this pathway to a fibrin clot. When we do a prothrombin time, we're looking at the extrinsic pathway. So we've got a reagent that activates factor 7 to 7A, 10 to 10A, and on down to the thrombin enzyme converting fibrinogen to a fibrin clot. And then we've got the Klaus fibrinogen test, which measures directly fibrinogen levels. We then have a thrombin time test, which looks at the thrombin, how thrombin converts fibrinogen to fibrin. So it tells you a bit about the function of fibrinogen, a thrombin time test. And so when we do prothrombin time, as you know, there's two methods that have been used. The first method that was used was the Quicks method, which had a separate tissue factor reagent, and the calcium was separate. So you've got your tissue factor reagent with phospholipid in it, and then calcium on the side. But most labs, most of us now use the Oren's method, which is a combined tissue factor, calcium chloride, phospholipid reagent. So all of us are using the same kind of reagent to measure prothrombin time. And the way we do it is we use 100 microliters of patient plasma. We incubate that just to warm it up to 37 degrees, and then we add 200 microliters of our PT reagent, and we measure the clotting time. So we either do it with a stopwatch and a water bath, or we look on an analyzer. We put it on an analyzer, and the analyzer gives us the clotting endpoint time. So we can report the prothrombin time in seconds. We can also report it in INR, as an INR if a patient is on warfarin. So the INR is calculated. We need to know what the international sensitivity index of the reagent that we're using, and that is always on the insert that comes in the box with the PT reagent. So to get the INR of the patient, we take the PT of the patient divided by the geometric mean PT of 20 normals. So those are 20 healthy controls. And we've done the PT on those 20 healthy controls. I've got 40 there. So you can use anywhere between 20 to 40. 40 is ideal, but sometimes that's hard to get that many healthy controls. So the geometric mean is the mathematical mean of those 40 PT results. And so PT patient divided by geometric mean PT of the healthy controls to the power of the ISI equals the INR. And that just means that result, the INR, is traceable to the WHO tissue factor standard. And it means that anywhere in the world where we get our INR tested, where all the labs are going to get the same result. So the aim of the INR is to make sure that patients are in the therapeutic range for at least 60% of the time when they're on warfarin. And also it's a safety result. So we're trying to avoid over anticoagulation and the risk of bleeding in patients on warfarin. So for reference ranges, I've just put this in here now. So every test that we do in COAG has to have a reference range. And we need healthy, normal controls. Ideally, we'd like 100, but often we will just verify the manufacturer's reference range, which comes on the insert of all your reagents. And you can do that by collecting 20 to 40 local healthy controls. We then establish it's the mean plus or minus 2 standard deviation is the reference interval, and that applies for the majority of coagulation factors that we measure. The PT, the APTT, thrombin time, clotting factor can all be established this way. So the APTT is not as standardized as the PT test. There's many different reagents out there with lots of different activators present in the reagent, and they have a source of phospholipid, and there's lots of different ways that the phospholipid can be made and added to that reagent. So these reagents are they can be compared to each other, but they are all very different, and that's why you have to have a different reference range for each reagent for the reagents that are used in each lab. So when we do the APTT, we're adding 100 microliters of patient-pooled plasma to 100 of APTT reagent. We incubate 3 to 5 minutes, and then we add calcium chloride, and we measure the time for it to clot. So we use a stopwatch in the water bath, and we get the time in seconds. So we usually report APTT in seconds. Sometimes we might report an APTT ratio, and that's really for patients when they're unfractionated heparin. That's the only time we need to report that ratio. So APTT can be abnormal in lots of different clinical conditions, including inherited or acquired bleeding disorders such as Haemophilia A and Haemophilia B. We can detect low factor 11 levels, inherited or acquired. We can also detect low factor 12 or other contact factors, but we know that these factors here, prekallikrein, high molecular weight kininogen 12, don't cause bleeding if they're low. We can also use it to monitor unfractionated heparin, not low molecular weight heparin or DOACs, but that will be prolonged when those anticoagulants are present in the patient. We can also use it for detecting lupus anticoagulant. Patients with liver disease, it's going to be abnormal. Patients with DIC, patients on fluids, and probably lots of other, clinical diseases that APTT may be prolonged. So I'm going to go through investigation of a prolonged APTT after I've been through the routine tests. So we've got the Klaus fibrinogen test. So this is a direct measurement of fibrinogen in the patient's plasma. So it allows us to quantify how much is present, whether the patient's got hypo or hypofibrinogenemia. It can also be discrepant in qualitative defects of fibrinogen as well, but we'd have to do another test to prove that a fibrinogen antigen test, which I'm not going to talk about. So when we do the fibrinogen assay, we make it's traceable. The calibrator that we use is traceable to an international standard. We dilute the patient's plasma 1 in 10, and then we clot it with high concentration thrombin reagent. So we can do that in the water bath. And then we get that clotting time and we read it off a standard curve, a calibrator that we've already prepared a curve with different concentrations. And we're able to read directly in grams per litre how much fibrinogen is in the patient's plasma. So fibrinogen can be low when it's got bleeding, when patients have DIC, postpartum hemorrhage, liver disease, they've had post-thrombolytic therapy, cancer, and then you have these inherited defects as well. So it's increased in inflammation and infections. Thrombin time test is a test where we're looking to see about the quality of the fibrinogen that's present in the sample. So we can use it as a screening test. So if it's very prolonged, we might be able to think that the fibrinogen might be low, but there are other reasons why the thrombin time test might be prolonged, such as the presence of unfractionated heparin in the sample, either because the patient's on anticoagulant, or there's been some contamination when they take the sample through a line that's been flushed through with heparin. That can also give you a thrombin time test that's prolonged. So we just dilute the patient's plasma 1-to-1 with a buffer, and we incubate that just to warm it up to 37 degrees, and then we clot it with a weak thrombin concentration reagent. So it's a much weaker reagent compared to the Klaus fibrinogen. The Klaus thrombin that we use is 100 unit. When we do the thrombin time test, it's weak. It's 1.5 to 5 units. Reference range is usually 12 to 16 seconds. So as I said, it can be it's always prolonged when unfractionated heparin is present and high concentrations of low molecular weight heparin. It's prolonged in dysfibrinogenemia and low fibrinogen, DIC, liver disease. And then we have this other test called a reptilase time test, which can help differentiate those samples which have got heparin present. So this test uses a snake venom called batroxaban venom, and this directly cleaves fibrinogen at a certain site and releases fibrinopeptide A and generates fibrin, the fibrin clot. So we mix the patient's plasma with the venom, and a normal clotting time for normal people is about 12 to 16 seconds. But when the patient is on unfractionated heparin, you have a prolonged thrombin time, but a normal reptilase time. So that helps us differentiate when the APTT is prolonged. We can use a reptilase time and a thrombin time to help us go which pathway that we're going to investigate, whether we think it's a factor deficiency or if it's heparin that's caused the prolonged APTT. So then I just briefly put D-dimer tests there. I'm not going to dwell on it. There's lots of different assays available, but we're measuring the final breakdown product of cross-linked fibrin using this D-dimer test. There's lots of different reporting units, microgram per mil, nanogram per mil, and a negative, it's used as a negative predictor value for the presence of VTE. So if your D dimer is below the cutoff, it's unlikely that you do have a DVT. But when it's positive, it's not specific for anything. And yeah, it's just positive high. So I'm just going to go through a little few results here and then some case histories to do with routine coagulation screening. So PT, APTT, thrombin, rectulase, class fibrinogen. So this is normal results. And I'll put the reference ranges up there for each of the screening tests. If I've got a patient with haemophilia A, which is factor VIII deficiency, I'm going to find an isolated prolonged APTT. So this sample's got 100-second APTT. When I do the thrombin time, it's normal. And when I do a 50-50 mix, which I haven't, an APTT 50-50 mix is an equal volume mixture of the patient and the normal plasma. And then we get a clotting time when we do that. We just do we make a mix in a test tube, 50-50, normal pool and patient. Then we do the APTT on that mixture and we get a clotting time of 43 seconds. We also know that our control was 31 seconds. So because this APTT is so prolonged, it hasn't quite gone back to within the reference range. 43 seconds is just above the reference range for the APTT, but it is a very good correction. And there is a formula that you can use to calculate how much the correction is. And I have given that at the end of this talk. So that's got an 83% correction and the cutoff is 70%. So that can indicate that that person has a clotting factor deficiency with this prolonged APTT of 100 seconds when you do the 50-50 mix. So when you've got heparin on board, as I was just saying before, we can have the same APTT as a haemophilia A patient, but when we do the thrombin time, that's very prolonged. And then when we do the rectulase, it's normal. So that immediately tells me that this sample has unfractionated heparin in it, and it's not a clotting factor deficiency. And if I've got a clotted sample, I'm going to get strange results. And these are sometimes the results that you might see. The PT is very prolonged, the APTT is very prolonged, thrombin time very prolonged, rectulase also very prolonged, and the class fibrinogen is often very, very low. So either your patient is very, very sick or there's a problem with the sample. And if the patient is not sick, very sick, then bleeding, then this is likely some issue to do with how the sample was taken, and it's just a clotted sample. So you can put in a stick into the sample and see if you can pull out a fibrin clot to check for that. Then we've got, this is a warfarin sample, so you'll have a prolonged PT. You'll also have a prolonged APTT because warfarin affects vitamin K clotting factors, and one of them is factor IX, which is measured in the APTT as well. So PT does 2, 7, 10. They're vitamin K dependent. So the PT will be prolonged on warfarin. So can the APTT because 9 is also a vitamin K dependent factor, and that's long. Thrombin time is always normal. And rectulase, we don't need to bother now. And class fibrinogen is always normal or high in patients on warfarin. With liver disease, it can be similar to warfarin, but the difference is they have usually low fibrinogens and they usually have dysfunctional fibrinogens, which you can pick up with a thrombin time. But you can have a very prolonged PT, prolonged APTT, prolonged thrombin time, a prolonged rectulase if you can do it. Class fibrinogen can be normal or low in liver disease. And then factor 7 deficient patients, they have prolonged PTs but normal APTTs and normal thrombin times. So then if you saw this in a patient, this here, you might want to think, oh, they've got an intrinsic factor pathway defect. So they've got a low clotting factor in that pathway. And you might do a 50-50 mix of the PT as well to see if that corrects. And then we can have patients with von Willebrand's disease. So they typically have a slightly prolonged APTT, but they would also have bleeding symptoms. And then you would need to go on and do a 50-50 mix too. And also you'd have to do factor investigations like factor VIII and von Willebrand antigen and activity to detect VWD. And then with the DIC, you can have various results with the DIC. You can have high or normal PT, high or normal APTT, high thrombin time or normal, and D dimers are up. Fibrinogen is usually down. So this is the ICSH calculation for the APTT 50-50 mix. I've put it there in my talk. And so with this last patient here, this one here had a PT of 13, an APTT of 45, which is prolonged, a normal thrombin time. And when we did the 50-50 mix, it didn't correct. It was nearly the same as the patient's APTT. So that if you did this little calculation, it would be a less than 0% correction. So definitely this is some kind of an inhibitor that we've detected in the APTT. And the most common one we're going to find is lupus. So I want to go through now factor assays. Is everything okay? Any questions? Nope. Okay.
If you don't want to speak up, you can pop the questions in the chat. I can see. No, okay, no questions in the chat. So if you don't want to speak, people, please put your questions in the chat.
Yeah.
And we'll pick them up from there.
Okay, thanks, Yvonne. So now I'm just going to go through how we're going to investigate. You might have already had this before, but how do we investigate a prolonged PT or a prolonged APTT if we think that they're factor deficient? So like the first result I showed you with the query haemophilia with a very prolonged APTT of 100 seconds, the normal PT, the normal thrombin time, and a good correction of the patient's plasma when we added normal pool. If we see that in a patient, we're immediately going to go, it's an isolated prolonged APTT that corrected. We're going to go on and investigate the patient for intrinsic factors. So the main ones that we're interested in are factor VIII, factor IX, and factor 11. And we do this by doing one-stage clotting factor assays. And these are all based on an APTT. So we have a standard sample and a test sample.
Sorry, Annie, I think you're not sharing your screen anymore.
Aren't I?
No, I don't think so. I can see you.
It says that I am.
Oh, okay, maybe it's just me.
So if I stop, it's got stop sharing on it.
Is it just me? Can everybody else see the screen or Anne? Nobody's answering me.
I can see the screen, Yvonne.
Oh, you can see the screen,
good.
not Anne.
Yeah.
It must just be me. Okay, then. Cool.
Okay, fine. That's good. So we have this unknown patient sample where we need to measure a clotting factor level. We've got a calibrator. So we have a standard that is traceable to the international standard. And we always construct these things in the same way. So I can say that the method for all of these things that I'm going to talk about now is in the World Federation of Haemophilia Laboratory Manual. And I've got a link to that at the end of my talk. But how to do these assays is described all very nicely in that manual. So we make a standard curve. And we have 3 dilutions. It's the minimum that we can use. If we use an automated coagulometer, they'll have 8 dilutions. But if we're going to use a water bath, we need test tubes. We've got our standard calibrator, and we make 3 dilution points. We make 3 dilutions, usually 1 in 10, 1 in 20, 1 in 40. And then we have our patient where we do exactly the same thing. We dilute our patient sample 1 in 10, 1 in 20, 1 in 40. And we then, I've been a bit brief here, but we're going to add the dilution into the test tube, we're going to add factor VIII deficient plasma, and then we're going to add APTT reagent. And then we're going to clot those mixtures with calcium chloride, and we're going to get a clotting time for each of these 3 dilution points for the standard curve and for the patient samples. We need to be able to detect down to less than 1 if we're going to diagnose haemophilia A. So when we're doing it, we've made our dilutions here of 1 in 10, 1 in 20, 1 in 40. We've put in factor VIII deficient to each one of those points. We then added APTT reagent to each one, and then we incubate for 3 minutes and add calcium chloride and measure the clotting time. So the 100% clotting time has come out at like 40 seconds. The 1 in 20 has come out at 50 seconds, and the 1 in 40 has come out at 60 seconds. So that's my standard. And then I've done the same thing to my patient. So my patient's 1 in 10 dilution has come at about 65. The 1 in 20 is 70 seconds, and the 1 in 40 is 80 seconds. So to read that, I would plot these on log linear graph paper, and that's how I get my patient result, which is 25%. So, yeah. So hopefully that is okay. So that's kind of a one-stage factor assay to measure intrinsic or extrinsic factors. So if I want to do 8, 9, or 11, I'll do it with APTT reagent and the specific deficient plasma. If I want to measure 7, 10, or 5, I'm going to do it with PT reagent and the specific deficient plasma, constructing the curve, the standard curve, and the test in the same way. So sometimes we can see whether there's an inhibitor present when we've done our clotting, our one-stage factor assay. When we have this test line here, it can be non-parallel. So say someone's got a prolonged APTT due to lupus anticoagulant, that can also interfere when we're trying to quantify the factors and the intrinsic factors like factor VIII and 9. The lupus may interfere, and it can give you this non-parallel line. We can also see if the sample is activated as well when we're doing a one-stage factor assay. So I've got this case here. It's a 3-year-old male. He's got a bleeding history for 12 weeks of age. He came into A&E with swelling on his left knee. He had large bruises over his iliac crest, and he was bleeding into his left foot, limping, and he had an ankle bleed. He also had swelling in his hands and his mouth. But prior to his visit, he'd also been placed under child protection because they thought his symptoms, 3 years old with all these symptoms, they thought they were a result of non-accidental injuries. But when he came into A&E, he had a blood test, and these were his results. He had a PT of 13. He had an APTT of 95 seconds. His thrombin time was normal. His fibrinogen was normal. When we did the 50-50 mix of his plasma with the normal plasma, we saw it was 34 seconds with a normal control of 31 with the NP APTT of 31. So that's an excellent correction. So we immediately knew that this patient had some kind of intrinsic factor, clotting factor deficiency. So it could either be 8, 9, or 11, or 12. No. Sorry, no. Sorry, everybody, nearly interrupted. Okay, and so we went on and we measured the factor assays. We did a factor 9 that was 90. We did an 11, which is 105. We did a 12, 120, and the factor 8 was less than 1 in this patient, and the VWF levels were, in the normal range. So we were able to diagnose severe haemophilia A in this child. And then another case, we had a 8-year-old male who came into A&E with an intracranial hemorrhage. He also had a strong history of bleeding, but he was also bled from his umbilical cord, and he bled at circumcision, had bruising. He bled when his teeth, when he had his baby teeth falling, when they fell out. He didn't have any epistaxis or gum bleeding. And these were his clotting screen results from the A&E sample. His PT was normal. His APTT was just slightly prolonged, but not drastically compared to the kind of history of bleeding that he's presented with. His thrombin time was normal. His APTT mix completely corrected as well. So we all again went on and measured the intrinsic factors, 8, 9, 11. So, but we did the full lot. We did 8, which was normal, 9, 11, and 12. 12 was the only thing that was abnormal. So we know that factor 12 deficiencies don't cause bleeding in patients. They're contact factors, and patients never present with bleeding, even when the level is less than 1. So the only thing that this could, where we've got this nearly normal clotting screen result, the only factor that we could be interested in, the patient might have a platelet function defect, but these were normal. And we looked at VWF levels and they were all normal. The bleeding time was also normal. And the thing that was was the thing that was diagnostic. We did a factor 13 screen, so a clot solubility test, which was abnormal. So it lysed away completely within less than 24 hours. And the normal is for the clot to stay in that test for over 24 hours. We then measured the factor 13 level by ELISA and found that it was less than 1, and the activity assay less than 5. So this child has factor 13 deficiency. So that commonly presents with bleeding, umbilical cord bleeding with a normal coagulation screen. And we're not, even though the prolonged APTT was caused by the slight deficiency of factor 12, it isn't the cause of the bleeding disorder. So then we've got another case where this is a 70-year-old female. She presented, she was on warfarin. She had DVTs and PEs, so she was on warfarin. She got referred to A&E because she had shortness of breath. Her laboratory investigation showed she was very anemic. She had a very high INR because she was on warfarin, just slightly above her therapeutic range. The APTT was very prolonged. It was 127 seconds. And she also showed she had a hematoma, a retroperitoneal hematoma. So she was given, they thought it was all down due to the warfarin. She was given red cells, FFP, admitted to a ward, but she continued to deteriorate and her hemoglobin kept dropping further. They stopped the warfarin. She was treated with even more blood products because she was still bleeding. And so they actually did do a coag screen at that point, and they found that her APTT was still very prolonged and that the mix, there was no correction with the APTT 50-50 mix. So on-call doctor said we needed to do clotting factor assays and an inhibitor screen. And this is what we found. Her APTT was prolonged, but not too bad. It didn't correct, 50/32, very poor correction. We did an inhibitor screen and it was positive after 2 hours. Her factor VIII level was only 2. And then we went on to quantify her inhibitor. We knew that she was 70 years old presenting. It's not hereditary haemophilia in a female at that age. It's always going to be an acquired haemophilia. And so this is just some pictures. Is a really good publication that's just come out about acquired haemophilia. And this was the timeline, just a summary of how we managed finally, 2 months later, nearly 3 months later, after she was admitted into A&E, she actually, that's not true. 40 days after she started warfarin, she presented to A&E with her prolonged APTT and bleeding. And then another 20 days later, they finally realized that she had acquired haemophilia. Okay, so inhibitor screens, I've just put up here how we would do an inhibitor screen if we thought somebody had an acquired haemophilia, or we wanted to see what kind of inhibitor might be present in the patient's plasma. We have there's tube A, which is just normal plasma. We have tube B, which is patient's plasma. We have tube C, which is a mixture of normal pool and patient's plasma. And then we put all those tubes into a water bath. We incubate them for 2 hours at 37 degrees. And then we make tube D, which is a mixture of tubes A and B, normal plasma, patient, incubated plasmas. And then we do an APTT on all those tubes. So if the results for A, and B, and C are all, and D are all within sort of the normal range, we haven't been able to show an inhibitor present in that patient sample. That's the normal, actually. And then result 2 is somebody who's got a clotting factor deficiency, where you've just got this prolonged APTT in tube B, which is the patient's plasma, but tube C and D, they fully correct. And if you've got an immediate acting inhibitor, you are going to see that tube C is prolonged and tube D is prolonged compared to, so you've got poor corrections on these 1-to-1 mixed tube C and D. And what we're looking for is in haemophilia, if you've got acquired haemophilia, you have an incubated mixture that correct on tube C that is much more prolonged than tube D's 1-to-1 mix. But this one is just showing an immediate acting inhibitor like lupus anticoagulant. So you can sometimes use this to differentiate between lupus anticoagulant and a factor VIII inhibitor, which is time dependent. So shall I stop now?
How much more have you got?
Just 2 slides.
Finish, it's fine.
Okay, so here I just put this up. This is just a schematic of a Nijmegen Bethesda assay. So it's just showing you the different kinds of assays that we can use to quantify factor VIII inhibitors or factor IX inhibitors, factor 11 inhibitors. So we've got a Bethesda type assay, which is what we would use for a factor IX inhibitor. We've got a Nijmegen Bethesda assay, which is what we use for quantifying factor VIII inhibitors. So I've given you all the references there. I'm not going to go through the methodology here because it's quite, I'll probably get myself confused and you as well. So, and that's the Bethesda curve. So I think I need to stop now.
Okay, that's fine. Thank you.
Because I think that's just getting too complicated.
Well, if everyone
But
is
it's all
interested, we
there.
can always ask you back to focus on that. So I'll let Zambia decide if that's something they want.
Yeah.
Dr. Sahar, you can tell me if you would like to have that and we'll organise that for the future. Okay, does anyone have any questions for Anne?
I think the Bethesda and the inhibitors can be arranged for another topic separate. But this is really was very nice and giving very much details. That is the basic.
Was it clear enough? Clear?
For me, it was very clear enough, but we can hear from the Zambian team as well, and we find out if there is any question.
I can see some Bukini has got their hand up. Do you have your hand up? Please speak up, unmute yourself and ask the question if you have a question.
This is our colleague consultant.
Yeah. Hello, Dr. Koa. Yes, it's Dr. Koa. Hello. Please ask the question.
Hi, I can go ahead. Thank you very much. Lovely presentation, very nice outlining of the basics. I just wanted to know, are we still using actual real venom? Current here mention of the dilute Russell Viper venom time. Is it still applicable? Thank you.
Yes, it is. If you want to, when we detect lupus, when we do lupus testing, we use dilute Russell Viper venom time with dilute phospholipid, and that is our screening test for detection of lupus anticoagulant. So we use that definitely all the time and that would be part of also possibly investigating a prolonged APTT as well. looking for lupus, looking for factor deficiencies.
Right.
Yeah, is that
Right. Okay.
so? Definitely, we use that all the time. Do you use it? Do you have it?
No.
Okay.
Yeah. You'd like to, right?
You'd like to, yeah.
Absolutely. I mean, we generally end at the mixing studies, and then
Yes.
anything after that, we'll have to refer the sample out for further
Yeah.
coagulation testing.
Yeah. Sometimes you can do the inhibitor screen, and that would tell you whether it was a lupus or an acquired haemophilia A. If you did that little inhibitor screen with tube A, B, C, D, some labs still do that actually. If they can't do a Nijmegen Bethesda assay, they can, but they can do a factor assay. They might do an inhibitor screen to see if they've got an immediate acting inhibitor like lupus or a time dependent one like a factor VIII inhibitor.
Right.
So I hope it wasn't, yeah.
I think that was perfect. Thank you so